Welcome to the Better Place Australia podcast series. The Hope Outreach program can help restore someone who's attempted suicide. Corey is the team lead of Better Place Australia's Hope Outreach program, and he shares insights into a day in the life of a person in the service, and he also de-identifies and shares a case study of someone whose life was turned around thanks to this service.
Generally speaking, we receive our referrals via clinical teams for Monash Health, and those referrals come into our centralised intake where we look at the referrals, try to understand the challenges that people are experiencing. We do have a set of eligibility criteria that we're required to screen those people with. But providing that they meet the thresholds, then we would accept a referral, and then a support coordinator would be allocated to a new client. Then we would arrange a first meeting. With the first initial assessment, we try to encourage people to come into our office because of the privacy and confidentiality, and are generally really related to the most recent self-harm or suicide attempt.
Yeah.
So we understand what people need. So we will talk to them about what were the things that were stressful leading up to your suicide attempt, what was worrying you, what are the things that we can help put in place so we can remove that stressor or that anxiety from you. And then we look at the referrals that we can then make for people.
Yeah.
People who may need to see a psychologist. So we would make a referral to a psychologist. Generally, we can find a number of sessions for people that don't cost them anything. So we're able to connect them with good mental health supports. Often there are accommodation and housing issues. So we might be advocating for a client on the public housing list, or supporting people to look for a rooming house to gain some sense of connection and a place to belong, because often when people are experiencing homelessness, they are quite disconnected from community. And the same about responding to family violence. A lot of our people that we support have had complex histories of family violence. So we look at what people need, we look at how they would like to address those issues, and also the priorities that they have, because people's priorities might be different to what I think are the priorities. So we make sure that we hold the person in the centre of these conversations and listen.
Yeah.
They might be financial stresses, they might be relationship pressures, and sometimes they become so overwhelming that people find themselves in a really dark place where they consider that their only option is to take their own life. So if we can work to remove the things that are stressing you, then we can help support you, because what we understand is in the first 3 months post a suicide attempt, people are up to 200 times more likely to reattempt suicide in that 3-month window. So we sit with our clients in that 3-month window to try and remove those stresses that they might have.
Yeah.
At the end of our service, they're either really well connected with longer term supports, because often things can't be completed in 3 months, but the foundations for that work can be put in place, then handed over to another organisation or another program. Or often people are in a much better place, and we can provide them with links to community supports, an understanding of where they might go if they start to feel unwell again, or start to have suicidal ideations again, whether they're passive or active.
So it's really crucial to reach out to them as soon as possible, isn't it?
Yeah, look, it's a 24-hour response generally, and often it's much faster than that.
Yeah.
We deliver those services in the community, but we're backed by a clinical partner at Monash Health. So we're able to facilitate referrals from other departments in the hospital much easier, because we're connected into the hospital systems.
Yeah.
the majority of our clients come after having a presentation in the emergency department. Then the second lot of clients would be people who've had an inpatient stay in a psychiatric unit. And then there are clients that are also being treated in the private service, but are connected to a public service. They're the only ways currently that we're able to take referrals is from inside the hospital system itself.
Right. Are you able to de-identify and give an example of somebody that you've helped personally?
Yeah, I can. I was very much involved in the early part of this year with a young gentleman who had a fairly serious self-harm attempt while admitted into the ED. He was quite distressed and extremely unwell. And we met with him almost immediately. And it was really clear to us that this particular person didn't really have a great understanding of their mental illness or their mental ill health and how that might impact when they stopped taking their medication. So this particular person had stopped taking their medication and they were living with a delusional disorder that was creating really strong paranoia. So we had to really work very carefully with this person to gain trust.
How did you do that?
Sitting, listening, allowing people to have space, and being curious to understand why the situation occurred, not assuming that we knew why, but actually asking why and taking time. And part of the key to good supports like Wayback, and particularly the way that BPA delivers those services, is we take our time.
So how did you go about addressing the issues they were going through so that they felt strong enough and they felt the hope that they didn't need to do the same course of action again?
Yeah, look, great question. What the actual ultimate outcome of it was to sit to understand where this particular person was coming from and to understand the medical perspective where this person was sitting. So what we were able to do is when we established rapport and with trust with this client, we were able to introduce them to a clinical social worker with inside Monash Health who was able to start a conversation around medications,
Great.
correct medications, correct diagnoses, and being able to provide this particular person with some factual information about illness, particularly around the dangers of stopping medication quickly.
Did you see a rise in hope with that person when they were going through this?
Yes, look, the outcome was very good. It took perhaps 6 weeks from the time that we met this person to they were in a better place because there was a psychiatric review of the medication that the person was taking. And for us, unfortunately, there is quite a delay sometimes in particularly getting a psychiatric evaluation, but we were able to link this particular person in with what we would call the continuing care team, or CCT. And they're a longer term clinical service that operates in the community that has clinicians assigned to a particular person, and that person has a general practitioner in the hospital, but also a psychiatrist linked to them. So that when we were able to share the care with the CCT team, they were able to look at the medications that the person was taking, look at some of the other psychosocial stresses that were going on, but predominantly for this person, it was a lack of perhaps understanding of their illness and an incorrect medication or a medication that needed to be reviewed and changed. So once that occurred, About 2 or 3 weeks later, this particular person was feeling a lot better.
Great.
They come to us and said, "What do I do now?" And our response was, "Why don't you think about going back to work?"
Yeah.
And he was like, "Do you think that will be a good idea?" And this young person was particularly lucky. They worked for a Big Four bank. So a permanent employee that had been on long-term sick leave because of this incident. We encouraged him to go to his boss and say, "I'd like to come back to work." And the organisation, to its credit, was amazing. They were able to assign him a return to work officer. So he was able to start to plan how he returned to work.
Great.
A bit of process involved around medical clearances and the like. But after 3 months, that particular person was back working 3 days a week.
So how long ago was that?
That was about 5 months ago.
And have you been in touch since? Have you heard of any progress?
Several times. He now works full time again.
Great.
And his medication is stabilised. He had a considerable process delay when he was unwell with his speech. That's completely gone now. His paranoia has gone, and he's been able to re-engage with his friends, with his social connectedness, been able to go back to basketball, been able to go and watch anime with his friends, which he was not able to do when he come to us.
That's Corrie, Team Leader for Better Place Australia's Hope Outreach Program. For more details, go to the Better Place Australia website and click on the Hope Outreach Program.